Thanks for joining me today on this episode of the DAX Monthly Healthcare Podcast. Today, we're going to talk about what's happening in the behavioral health markets, digging into M&A, digging into investment, but also just digging into what's happening with the new administration. You are the co-chair of behavioral health at Polsinelli. What's your take on what's happening right now? What are you seeing?
Well, Melvyn, it's great to be here. Thank you. Always enjoyed talking with you, and honored to be on your podcast. What's happening in behavioral is probably microcosmic to what's going on in the world in its own way. Behavioral is a active sector of the healthcare economy and has been over the last several years. It's an area that our society has increasing needs for, and or increasing awareness that there's need for treatment of many different types of mental, behavioral, or developmental conditions. And there are, evidence-based, scientific, efficacious ways to treat the various different lanes of it. Behavioral is not just one thing, it's an ecosystem ranging from psych hospitals on the high acuity side to outpatient clinics, psych practices, autism treatment, eating disorder treatment. There is overlap for sure, but they're all very much their own things, with the layer of technology-assisted care coming in around that, doing some of those same things synergistically or disruptively to the existing landscape. And so you have this robust area within healthcare with a lot of energy, innovation, investment. At the same time, here we are in the beginning of 2025. We are living in an interesting political moment. A lot of the access to care improvements that we have seen have come through the Affordable Care Act and the expansion of Medicaid. The Medicaid expansion has put more federal funding into state Medicaid programs in a number of states who've opted in. Right now, under the Republican administration in DC, the Medicaid system is viewed as vulnerable to change, possibly drastic change, to balance the federal budget, be able to afford some of the administration's priorities. And it seems to be, if you read the news, including today, Medicaid programs and the amount of funding that the federal government puts in is being rethought. It is not yet known exactly how that's going to happen. When all is said and done, it will impact the healthcare system, and how it will impact behavioral health is something that remains to be seen. Behavioral health is an area, generally speaking, in terms of the opioid epidemic being a very public and visible issue, that it is hard to imagine, or you wouldn't want to imagine, changes that impact that level of care. It's really life-saving care, and we're struggling nationally with the fallout, including where I sit in San Francisco.
Yeah.
And it's not just blue states that have this issue, it's a lot in the heartland as well. And so it is hard to imagine this level of care being disproportionately disadvantaged, but it is an unknown. And so when I say we're a microcosm, we're living through the same uncertainty that others are, but within behavioral, we are dealing with a little bit more of a vulnerable population. And stay tuned to see what happens and comes out of DC. We are certainly hoping, for the sake of the Medicaid members and providers who rely on that level of reimbursement to provide care, which is still highly needed and not as available as it needs to be, to ensure that there is access to care. So from the big picture, we're at an interesting moment in time.
Sure. I think that makes a lot of sense. And I know there's been a lot of headlines about the Department of Governmental Efficiency, about RFK, about Dr. Oz taking over. anything so far that's come across as an idea, as something that's been passed around the House or the Senate directly affecting behavioral health that you are concerned about for your clients, for the industry overall, or still a bit too early?
That's a great question, and one that's very interesting. I have been watching with great interest RFK's public commentary. He has said a couple of different things that are notable that may preview as background what ultimately happens, which candidly, I don't know better than anybody else who's not in the administration. But some of the commentaries he has made, we know that, vaccines is not a big area of fondness for him. But more specific to behavioral, psychotropic meds is something that he has voiced some skepticism towards. SSRIs like Prozac, Lexapro, things that are, have been the standard of care, efficacious in helping people with behavioral health conditions from anxiety, depression, in that spectrum, supporting people who are in recovery, are things that RFK has come out against, but he has also, I think, tempered that commentary. And so there is a question around how medication supported care is going to evolve or be impacted. Medication supported care is similar to, but distinct from, medication assisted treatment. Medication assisted treatment is usually a term for opioid addiction medications like Suboxone and Methadone, which are in their own category as an area that has become very much the standard of care in addiction treatment, opioid addiction treatment in the United States, around the world. And to the extent that there are pressures on how that kind of care is delivered, it would be impactful. There is tension between the delivery system we have now, separate from the question about are meds good or meds bad, but there is tension in how telehealth accessibility can be leveraged to make medications more widely available. There is been an act in Congress, MOTA, to allow individuals to receive methadone in drugstores. That is counter to a lot of how the American healthcare system has treated this medication and the requirements to receive counseling, wraparound services, and control the medication. And so you have a lot of clinic-based programs that are keeping people alive every day, who are watching carefully on where they can expand their services, what types of issues or challenges may come up to their business model due to regulatory and reimbursement changes, at the same time as some anti-PE in healthcare from the left. So we can get into that a little bit also. The tension between how these forces from both the right and the left are going to be interesting to see how they play out. Where are their alliances? Where are their splits? The last thing I'll say to your question, RFK has said that wellness farms is a way to have treatment, and it's not treatment, because treatment involves licensed clinicians delivering evidence-based care.
Sure.
Wellness farms are places where people go to live drug-free and work in a community, away from the distractions and risks of their home environment. And there may be merit to the wellness farm idea. I will say, though, the concept of wellness farms sounds a little bit like some things that were tried and did not work in the 60s and 70s that turned into cults. There's a whole side story as to the Synanon group in California, which ran basically a version of wellness farms for people who had opioid issues in the 60s and 70s and were not a fit for AA at that time. Synanon had a bunch of places where a bunch of people were doing this type of drug-free lifestyle, which was not healthcare and was not paid for by insurance or Medicaid. It was it did receive, I think, in California, some state level support, but the bottom line is it turned into a cult with a militia and
Oh boy.
tax abuse, evasion. Are they a church? Are they not a church? And the whole thing exploded in a giant phantasmagorical story that is, to me, interesting and fascinating. And to a comment you made earlier, history in some sense may repeat itself. And I hope we do not, as a healthcare delivery system, find ourselves faced with places where individuals with serious behavioral health conditions go that need clinical care, supervision, standardization, some level of oversight of how these people are supported in treatment and recovery, being thrown into a environment where the supports that we have seen that work and help people stay well and save lives are sacrificed. That is a very long run-on sentence of what's going on in behavioral now. But these are some of the things that I think about as I see what's going on in the headlines.
Yeah, I think it's a great overture to what's happening in the space and the ecosystem. And I think to your point, folks that are further along on the acuity spectrum, they don't need for benefits to fall away and proven evidence-backed methods, modalities of care going away. They need that to stay around. So hopefully we don't see a dismantling of the treatment ecosystem as it is today. Hopefully there'll be some more investment that comes from maybe some loosening of the right regulations so that folks can get involved in a better way, but maybe tightening of others. And I know even in the last few months, Gavin Newsom, you talked about private equity just for a second there, and it's probably a good segue into M&A, but Gavin Newsom was looking at, in California, I think putting some incremental stipulations on how private equity can invest in healthcare. And I don't believe that was passed, which is probably from a deal-making standpoint, a good thing. But not sure if you have any thoughts on that, because California is always an interesting market when people talk about M&A because of the regulations.
Totally. And I'm glad you raised that because that is how we see the challenges manifesting from the, I guess, political left. California is a blue state. There was a bill that made its way through the legislature at the end of the last session to require the Attorney General's affirmative approval of healthcare transactions where the purchaser was a private equity firm or there was other, PE involvement in the transaction, and it got vetoed. The reason for the veto given by the governor, I think, was a very good one. It's duplicative to the Office of Healthcare Affordability, which just got implemented 2 years ago and requires many types of transactions to be reported for data gathering to assess impact to cost of care and accessibility of care, and to come in right behind that and put on a whole new regimen to put the AG basically in charge of large swaths of our healthcare system seemed, a bit overreaching, and fortunately was vetoed. Many of our clients were watching that with some concern. A lot of the PE groups we work with as well. I've got good news and not so good news. The not so good news is that just in the last couple of weeks, a version of that bill has been reintroduced in the legislature. The better news is that they have focused it on a more narrow set of regulation around enforcement of California's corporate practice of medicine. This is something intended to preserve clinical independence. A lot of the requirements are already part of our state's law. And so it just reinforces and gives the AG oversight over MSOPC arrangements where an investor is engaged in managing a healthcare practice. The transaction approval part is not been reintroduced, which I think is good. We're still in the early days of our state legislative session, and it'll be interesting to see how the bills evolve or anything else comes up. A couple of other states have popped up, Indiana, Pennsylvania, others that we're watching. And we see, while at the federal level, it's regulation from the right, including loosening of a lot of the federal antitrust infrastructure that had been built up in the Biden administration, subject to the things we talked about earlier around Medicaid and models of care. At the state level, we see a lot of groups seeking to rein in PE, and you'll have to pardon me for saying this, taking what I consider to be a tired PE is the bad guy storyline, which is one, wrong. There are firms that are doing great work to invest in, expand access to necessary care in ways that are more efficient, better run, with greater oversight and support. And there have also been headlines, unfortunately, of a few instances where PE investment did not have good outcomes, and in hindsight being 2020, things done that perhaps should be better regulated. But to take a all-inclusive PE is the problem approach is, to me, jeopardizing access to care, needed investment to provide that. And for a long time, particularly in behavioral, and maybe even to this day, the major health systems don't feel as comfortable in it as handling primary medical. Behavioral got shorn off from the healthcare system. And
Sure.
I think investor, entrepreneur, mission-driven groups kept it alive and are keeping people alive, to this day. So to avoid dismantling or harming that infrastructure through some sort of a political, let's put some genie back in a bottle because we're afraid of what may happen, to me is, I don't think it is helpful. I think more nuanced, focused regulation, working with the positives that can be brought in from investor involvement in healthcare is a more, thoughtful and measured way to go. And jury's out on how that applies. It depends a lot on what states you're in, what happens in the states that you're in. As you said, I'm here in California, and other things that are playing out. I will say we see a lot of these and work on a lot of transactions nationally, and it is important to understand the nuance in the regulation. State can have a process. The process is defined in particular ways, applying to particular providers. There are policy decisions that go into them. Just like you have a wide variety of different types of behavioral, you also have a wide variety of health care types and regulation types. And, that gets into the type of stuff that we, feel for our clients on a regulatory basis in the context of deals.
Yeah, I think it makes a lot of sense. And I think to your point, if you think about Trump administration, the last go around, there's a lot of his agenda that he got by, not necessarily by doing the work at a federal level, but saying, hands off, I'm going to let the states handle this. And I think what we've seen since then, we see it with longer approval timelines with chows in different states, extended oversight, sometimes 30, 60, 90, 120 days of what it used to be before, especially in, you're in California, I'm here in New York, two states that tend to be heavily regulated. But to your point as well, private equity can be a real source for good in this industry. The entrepreneurs are great. There's a lot of people that have an emotional connection to the space, having gone through recovery themselves, and they have it in their heart of hearts to go out and build something. Not 2020 to 2022, we saw a really big wave of consolidation. It's been a little slow the last few years. I know you're on the front lines. What are you seeing with M&A? What's happening right now?
Great question. And yes, that lines up with our experience too. The last 2 years were slower, still a good number of deals getting done. Typically, they were taking long for the reasons you said on regulatory considerations, as well as buyers just being more cautious and wanting to do diligence a little more thoroughly than perhaps was the case in late 2021. Since the beginning of this year, JP Morgan was a place where we saw a lot of, right here in San Francisco, people came in, a lot of discussion that has now turned into reasonably good number of new for 2025 M&A deals in behavioral. We have transactions on both the buy side with PE clients or portfolio of PE clients. We have a number of sell side projects that are going, and the investor appetite remains to create larger scale within behavioral, to invest in expanding platforms that are doing good work, to leverage the reimbursement dynamics and managerial efficiencies and the know-how of how do you provide good care in a way that is sustainable financially. For as much as voices on the political voices perceive that there are ill effects of private equity, the bogey person under the bed, I think in the real world, patients and healthcare providers are feeling a lot of pressure and have been from the real 800-pound gorilla, which is the payers. Dealing with commercial insurance payers, navigating government reimbursement rules, which vary by state, the pressures that have come from within behavioral, higher spending by the payers, leading to payers taking a greater interest in scrutiny to require pre-authorization widely for care, but beyond that, limit the length of stay, put people in lower acuity levels of care, deny, claw back, audit for a whole host of reasons that in our day to day, when the dollars get to a certain level, folks call lawyers who know how to help resolve and have the playbook for payer disputes. And in order to do that, you can't be a mom and pop. You can't be a 3 or 4 facility place. You're dealing with a payer who's very, very well financed, who will pick pretty smart battles. And it can be very, very challenging when you're fighting the hand that pays your operating expenses. And so there's a few tactics that go into this. We don't just, get right to a lawsuit footing, which is also expensive and distracting for providers, but there are some things that need to happen to ensure that people are fairly paid for the services rendered and patients are being given the benefits, notwithstanding the talk that we've heard about parity. So, there are a lot of factors that go into the need for investment, not just in the healthcare providers to grow networks, but in the technology assists that make those providers effective. And so we've seen a lot of interest in RCM platforms, technology assisted ways of giving providers tools to document their care, to utilize, and this is, I think, still early stage, but AI related tools to ensure that someone is keeping an eye on not the patients. We still need clinicians to do that, and licensed healthcare providers, but to efficiently make sure that everything is in order in the very complicated puzzle of delivering, administering, and being paid for care. So a healthy M&A pipeline right now across ABA services, addiction treatment, outpatient mental health, multi-residential subs. I'm looking at LOIs on my desk.
There
are
a lot of LOIs.
IDD. It is hopefully going to be for advisory professionals like yourself and me, a return to helping our clients achieve, their goals transactionally. And it's keeping us busy.
Yeah, for sure. I mean, you touched on a lot there. So much to unpack. I think a few things that really stood out to me. The general comment, which is, I think, a big reason why a lot of folks are doing M&A is you're negotiating leverage with payers, your ability to scrape make sense of and position data so that you can negotiate better reimbursement rates and then hold on to those rates depending on what level across the acuity spectrum you're providing care at. Doesn't matter where you are in the healthcare system, everyone has to fight that fight. We have clients in value-based care, which is further along the spectrum in terms of sharing data, post-acute space, and then behavioral health. And behavioral health is definitely at, I would say, an infancy stage compared to those two other sectors.
Yes.
But companies that can do that have a better time with payers, and they also have a better time in due diligence, because a big haircut that we see is just the belief or lack of belief of buyers in the strength and durability of reimbursement. I mean, that's a single greatest driver to unit economics for a business. The other comment that you made that stayed with me, and we'll talk more about technology later, is how AI is coming in, or not even AI, just automation. And I think a lot of these either EMR, RCM billing companies in the behavioral health space, they're sitting on troves and troves of data. How are they going to use that data to empower their client base, the providers, to negotiate with payers, to do a better job, perhaps even with predictive analytics, to help them provide a better quality of service, and also just collect more of what they're billing, which, as we know in the space, is not something that's always easily done. The last thing that you mentioned that stood out to me was autism, IDD. Obviously, there's that big transaction that came out with Nautic and Proud Moments just a few weeks ago. It's February 26th that we're coming out with this podcast. The autism space was really slow the last couple of years, but started to kind of perk back up at the end of last year. So one thing that we've been seeing is larger private equity groups, curious what you think about it, larger private equity groups saying, we don't want to be the first to do a deal here. And folks that have invested, 4, 5, 6 years ago, still hanging on to assets for a variety of reasons. So we think that bodes well for the market. I was just at base in Miami a couple weeks ago, and a few things that I noticed as well was, one, a lot of non-institutionalized businesses with owners in the, let's call it 2 to 10 EBITDA range, thinking about either exiting this year, now trying to price in full year 25 or waiting a little bit till 26, but feeling more ready than they were a year or two ago. Also seeing from the standpoint of strategic initiatives, folks wanting to be more patient than maybe they were in the past, saying, hold the phone right there. I'm not ready to go and do a deal, partially because I think valuation, which having more of these larger PE deals come to market and eventually exit will help things. And I think lastly, too, your comment about the buy side, a lot of groups realizing that because there is not a lot of, I don't want to say talent in the space, but talent to work at a more scaled behavioral health entity, doing acquisitions is becoming more and more important. But making sure the clinical model fits, make sure the culture is there, and there's certainly a manageable level of reputational risk, I think, is something that everyone is digging into and realizing that, it's hard to grow either way. There's pros and cons with either direction.
Agreed. That all lands, very true here. And perhaps additionally, we have some family office clients who have significant healthcare operations who continue to have appetite and grow and see behavioral as a natural synergistic expansion to holdings in other parts of the healthcare economy who've been undeterred, even in the leaner years that we've had, and have had great success in a quieter market, and are continuing to be active, building on what they've learned works. And I think it could be later this year, we look back at 2024 as oh God, if only we were in the market when multiples were down at whatever level, because now there have been some platforms who've traded. And I mean, it wasn't that long ago when a lot of a sell side process would be multiple offers, buyers maybe being a little leery about getting involved in a overbidding fatigue process where you just invest so much time and energy, and you're just one more potential buyer in a crowd. I think it wasn't that long ago where people were viewing it was just more based on the demand side. And so hopefully we see a healthy market that helps achieve the goals of delivering quality, effective care, building value, helping in behavioral, which remains one of the great areas of, both societal investor and policy interest, a healthy healthcare delivery system.
Yeah. And I think to your point, maybe we'll look back in a year and say, Acadia did do that transaction last year with Turning Point, which they hadn't really done much for a while, but Acadia, LifeStance, some of these bigger names getting back into M&A, I think that's something that sends a positive signal. We'll look back and say, that was the turning point when a group like that or a larger sponsor had an exit, and processes became more lively. But turning the page a bit, you talked about some of the buy sides you're working on. What are you seeing right now? Is there a major difference in terms of what buyers are digging into now versus 6 or 12 months ago?
No, I think it's, ABA and IDD, there's just more of them happening now.
Yeah.
ABA did have a little bit of a lull, as you said. IDD does seem to be more active right now than we've seen it. Eating disorders has been quieter. Substance abuse, mental health, residential, outpatient, psych hospital, level of care, PHP, IOP, all of those are very active and I think have had pretty robust interest relative to the market in behavioral over the last 2 years. And I think there is some inflection in the multiples, but in terms of what buyers are looking when they find an asset, we are continuing to see processes that are, and I think this is going to be the new normal, compliance, chart review, ensuring that the reimbursement thesis for the business is, sustainable and is, built on a good foundation, to avoid, having to retrench after closing because, it wasn't being done with all the I's dotted and T's crossed, which I know is challenging in behavioral where there are evolving care modalities and the back and forth with payers. But I think we are in a new normal in terms of when people are engaged in a process, wanting to ensure that they've covered all the bases. And I can see even in a healthier deal environment that will continue to be the case. We cover some of this stuff in our new for 2025 top issues in behavioral health newsletter, which I flipped over to you. And, I think that's just got a distillation and a little bit more color of how some of these things play out if you're on the buy or the sell side.
Yeah, I think that makes a lot of sense. And are you seeing similar, let's call it similar work play out when you think more on the de novo side of things or the, the minority investment side? Or are you seeing different factors there?
Great questions. On the de novo side, there remains appetite. The appetite in the last 2 years has been pretty strong on de novo. You have a lot of, assets being repurposed for one thing from other types of healthcare into behavioral uses because there's just not enough, there's too much white space in behavioral. Systems that are looking to expand are viewing, and I think continue to view de novo as a lower cost, lower risk way to get in. And the de novo projects often look a lot more like a real estate deal.
Sure. Yeah.
Especially if you're dealing with residential level of care. And, there is a playbook in terms of legally what corners to look around and how those deals get structured. But we do know that there is good appetite from the real estate investor side to step in and help finance growth projects. And that has and continues to be a robust place to support expansion from the de novo perspective. From the joint venture side, it is hard to generalize because you have, very large JVs with behavioral and hospital systems, developing new high capital intensive psych. There certainly has been a lot of that over the last several years by high profile players. On smaller mid-sized deals, I guess I would say people who are thinking about doing this, it's never too early to get good counsel and make sure that your documents are as state of the art as they can be. It is often the case, even where you would be surprised to find it, that the sort of ownership documents, the relative relationships among the parties has not been dialed in as much as you would like. And where there is uncertainty and then later disagreement, it can become costly to unwind those types of issues. So entrepreneurs are still largely getting involved in this space, and for a lot of very good reasons. But then once something becomes scalable and people have different views of where do you go and who has control, and should we sell, should we continue to operate, are we distributing money, are we going to continue to invest, I really would say it's never too early to think about those things and have a nuanced set of legal terms that'll be supportive and sustainable, and hopefully have clear guidelines to avoid some of the cost and confusion that comes when people are not seeing eye to eye later.
Yeah, cost and confusion, and also risk. We're working with a deal right now in the treatment center space, and there's some corporate docs that were not drawn up correctly. And now that we're going in and trying to work through a sale process, there's been a lot of scrutiny on those, which has frankly forced us to narrow the scope of our process versus being able to go broader, because it's going to involve some, I don't say creative structuring, but when you don't spend the money or the time to paper the docs correctly, it will come back to get you. And unfortunately, if you can't have a more competitive process, sometimes it can be an issue.
Yeah, I mean, you leave money on the table and shorten down your options, and probably spend more time back and forthing inside your own constituency on the sell side than you should or could. And we've seen a few more of those types of situations, and we can help our clients get through them. Some of them involve renegotiation. Sometimes it's renegotiation after some legal fists have been thrown. It's not pretty. For the deal professional M&A side of my practice, much happier with a clean deal and get it done. But when we have to get the litigators involved, it can become a little bit of a different circus. So the experience you relayed lands here, and that's what I was getting at with your question.
Yeah, no, it totally makes sense. And as one last area we should cover here is where we kind of come up on time, behavioral health technology. I think there's been probably as much or more investment on the technology side of the spectrum as the provider side of the spectrum, and it's across the ecosystem. You've got your EMRs, you've got your RCM businesses, you got your CRMs, you've got everything in between. What are you seeing in that part of the space?
Well, right now, the most reliable plays in tech, to me, are the ones that are helping existing providers, established providers, do things more efficiently in the ways we were talking about earlier. It's like, the equivalent in the gold rush of selling shovels and tents to the prospectors. Sure. It's a steady business. There are going to be prospectors. The provision of new technology assisted things that are going to materially expand on a much more cost efficient basis. The magical golden nugget of, oh my God, now everybody can get telehealth. Yes, telehealth is a more efficient way to deliver some kinds of care, like one-on-one therapy, but it does not cover the whole range of things that are needed for all patients. And so you have parts of this that become exciting and interesting as the technology and society evolves. I don't know that I've heard of any great moonshots. AI is not going to be treating people anytime soon. I've read some bad headlines on what happened when some avatars gave some bad counsel to people. It was not counsel. It was AI. But hold the phone for that. I think that stuff is more effective on the back of house business process stuff. GLP medications apparently have some relationship or efficacious impact, and so stay tuned for whether that turns into a, oh my God, we also are now able to solve a whole bunch of other healthcare conditions through a better medication intervention. So there are things that could happen, but there are not, to me yet. We'll know what the unicorn is in hindsight. And I haven't seen anything that's been an amazing unicorn that's disrupted it. I know there are innovators on medical device software. They're working on projects involving both of those, but getting something into an institutionalized, this is now the standard of care, everyone who is well advised is pursuing this, that has consumer, patient, clinician, payor adoption, and you can get it at the touch of a button. We could be sitting here next year and it could be sitting there right as the app in everybody's phone, but you have pieces of things that are still part of a healthcare ecosystem that continues to evolve underneath the forces, societal market, reimbursement, investment that we were talking about. And so I think you are continuing to see innovation, but as we sit here today, some of the companies that were investing heavily in sort of digitally assisted care that were hopeful to become the unicorns during the COVID era, not all of those stories turned out happily. And bottom line, in the real world, a lot of the telehealth is being delivered one-on-one therapy, and the reimbursement rates for one-on-one therapy they're just not amazing. So it is not, it can only advance so far as the forces that we're working with will allow it. That was a little rambling at the end, but it's a way of saying continued experimentation that I think will move things, but has not exactly happened just yet.
Yeah, I think that makes sense. And I think investors, because of what's happening upstream in the software markets, there's a lot more maturity, especially when you look at the public markets and companies that IPO'd a while ago. And there's only so much growth they can have. And I think behavioral health is going to be a specialty area that a lot of investors are looking in. I think about companies like, even if you take the EHR space, like Kipu has done some investment. You've got Sunwave, you've got Aliva, you've got Opus. There's only so many groups. The TAM is probably half $500 million to $1 billion, somewhere in that range, if you account for growth, which there will be a lot of growth. But there's going to need to be dollars there to build those business models, and for someone to really come out as the leader. Even though I think today we'd argue Kipu is probably the largest. Depends on who you talk to, who's the best, right? Who's best at breed. And to your comment as well on bad publicity with AI and prescribing, I was at a conference with Bernstein a couple months ago, and there was a big roundtable about this. And the only real use cases right now for AI in healthcare are really, digital scribe, which you still have to review those notes, and autonomous coding. Because anything that requires diagnosing and then ultimately prescribing, you need a lot more human intervention to make sense of the data, which is why I think a big area for behavioral health, maybe it's not AI, but a word we talked about a decade ago, big data, making use of that big data, not just to make decisions, but also to have some modicum eventually of value-based care would be a good thing. But we're probably still quite a ways off. And that's thinking pretty far ahead there. There's a lot of room to go.
Yeah, as you were saying that, I was just talking to one of my professional contacts yesterday, and it's not specific to behavioral, but he mentioned something called Lumeris, which
Hmm.
is on my reading list. But I guess the idea, as I understand it, is they have a AI enabled care coordination. So the AI interfaces with the patient before the care episode. It's not giving care, but it's doing all the stuff around the care
Yeah.
in a way that arms the patient with a better level of visibility over what they're going to experience and how to, orient in that does not require um, human intervention, um,
Yeah.
scheduling, care coordination, chronic disease management. It's a primary care uh, intervention at this point. I could see something like this being utilized and leveraged in behavioral, because so much of what we see in behavioral is you can have a successful primary treatment episode, but then aftercare, fill in the blank. But if you can
Yeah.
utilize something that keeps patients engaged in their care plan in an effective, well developed, smart way, I think that's on my reading list. Hot off the
Yeah.
presses yesterday. I heard the demo was pretty exciting, and shout out to my friend Ellis Metz for putting that on my radar yesterday.
I got to look that up too. It's like when you think about provider engagement as well, but not just provider from the standpoint of the business, but provider from the standpoint of the clinician. Recruitment, retention, not as bad as it was during COVID, but there's still a lot of wood to chop there. I think there's also going to be a use case for using some of this data and this technology to improve that as well. And gamification, I mean, you see it in post-acute and a few other areas with companies like Perry, to your point. But it's the same thing on the patient side with aftercare and staying engaged. And as we know, unfortunately, alumni are often a big part of the revenue of some of these facilities. So stay engaged with them if there is some sort of relapse or a need for additional, more acute care is probably a good thing.